ask. So just pop into the chat quickly, just 1 or 2 questions that you might want to ask her. Yep, any unprotected sexual intercourse. Bowel movements, yep. Okay, so all good ideas. And given the location of the pain, which set of differentials are we thinking of, given that it's right lower abdomen? Yep, if they diagnose any condition like Crohn's, yep. Ectopic pregnancy, yep. Ovarian torsion, yep. Appendicitis, yep. So in terms of the differentials, we can split the abdomen up into 9 different areas. So known as the right hypochondriac and left hypochondriac, epigastric, the right and left lumbar or the right and left flank, the umbilical area, the right and left iliac fossas, and the hypogastric area. Now, given the location of her pain, we're thinking of conditions on this side of the abdomen. So possibly a urinary cause, a gynecology cause, or a GI cause of her pain. So in terms of the examination, this is what you find. She is tachycardic and hypotensive, and she's also spiking a temperature. On examination, you see that her heart sounds are normal and the chest is clear, but on abdominal palpation, you note that there is pain in the right iliac fossa on superficial palpation. There is pain also felt in the right iliac fossa when the left iliac fossa is palpated. So what is the name of the sign when pain is experienced in the right iliac fossa when the left iliac fossa is palpated? Brilliant. So from the votes we've got in, it's Rovsing sign. So Rovsing sign occurs when you palpate in the left iliac fossa, and that causes pressure to build up within the colon. This pressure then gets transmitted throughout the colon, and that's why it can be felt on the other side. And this sign is usually seen in conditions like appendicitis. Now, the other options in that questions were also GI, other signs that can be seen in GI pathologies. So we'll just quickly go through them now. So psoas sign is also seen in appendicitis, and this occurs when you get the patient to lie on their front or on their side and get them to extend their right hip. The reason this happens is because the appendix can lie in different positions in relation to the cecum. Now, the most common position for the appendix to lie is retrocecally, so behind the cecum. And when the appendix is inflamed and you get the patient to extend their hip, this causes the inflamed appendix to rub up against the psoas muscle, and that's why they get the right iliac fossa pain when they extend the hip. Next is Murphy's sign. Murphy's sign is seen in conditions like cholecystitis, and this occurs because the gallbladder lies in the right upper quadrant, and when it's inflamed, it can cause this sign to occur. So you ask the patient to take a big breath in, and when you palpate, it causes them to stop breathing because of the pain. And this occurs because the inflamed gallbladder hits your hand. So that's Murphy's sign. The next sign that was on that list was Cullen's and Gray-Turner sign. This is when there's bruising around the periumbilical area and on the flanks. And this is a sign of retroperitoneal bleeding. So any organ or structure behind the peritoneum which is bleeding causes this sign to occur. And to remember which one is which, Cullen's, you have to draw a C around the umbilicus, so that's Cullen's, and then T is for Turner's, so you can draw a T on the flank there. Now, when I say which organs or structures can bleed retroperitoneally, there is a mnemonic called SAD pucker. which is just a way of remembering which organs or structures lie behind the peritoneum. Things like the colon, the aorta, the ureters. Everyone will get a copy of these slides, so you can go through that mnemonic in your own time. So now we want to order some investigations for Alexia. So, and these investigations can be split up into 3 broad categories. The first is bedside investigations. So we want to do things like a urinalysis and a pregnancy test to check to see if she is pregnant or if she has a UTI, for example. Bloods are like that we can order, including FBC, CRP, group and screen, LFT, and also a pregnancy test if a urine pregnancy test is not available. This rules out things like bleeding, infection. We want to get a baseline just in case we need further management of this patient and to see if she is to confirm pregnancy. And next, imaging. We can consider things like an ultrasound or a CT scan to look at any abnormalities in the GI tract or the genitourinary tract as well. This is an important point to make because in any female of reproductive age presenting with abdominal pain, it's important to rule out pregnancy. And the reason we want to rule out pregnancy is because of something called an ectopic pregnancy. So during pregnancy, the embryo usually implants itself into the uterus. If it doesn't implant in the uterus and implants somewhere else, it's called an ectopic pregnancy, and it usually implants in the fallopian tube. If this pregnancy in the fallopian tube or outside of the uterus grows to such an extent, this can cause the pregnancy or the fallopian tube to rupture, and that can cause a life-threatening bleed. That can cause damage to the fallopian tube and cause fertility and subfertility issues down the line. Question, in the exams, are we okay to say FBC or do we specifically mention what's in the FBC? So in terms of the, in exams, you can say FBC, but they usually want a justification as to why you'd want to order an FBC. So for example, if you're thinking of infection, you can, they'll say, you can say, I'd like to order an FBC to look at the white cell count to rule out an infection, or something along those lines. So what hormone is detected in serum or urine in a urine test to confirm pregnancy? Yep. So answers in. So the majority of people have gone for B. So in pregnancy, we're looking for the beta HCG to confirm whether or not someone is pregnant. So other important gynecological causes of abdominal pain include ovarian rupture and ovarian torsion. Now, ovarian torsion is another important emergency presentation to be picked up because when the ovary twists on itself, this can compromise the blood supply to the ovary. And if the blood supply is compromised, this can cause the ovary to die and then cause further issues down the line like subfertility and infertility and also rupture. So Alexia's results come back and her urine dipstick is negative and the pregnancy test is negative. The bloods showed an elevated white cell count and CRP, and she had an ultrasound which showed normal ovaries. However, the appendix was not visualized. So given everything in terms of her presentation, her investigations and examination, what's now the most likely diagnosis? The rupture of which particular structure? Yeah, so we're thinking this is a case of appendicitis. Now, the reason why I wrote that the appendix is not visualized, because do we need imaging to diagnose appendicitis? Well, for the majority of cases, imaging is not essential for a diagnosis of appendicitis to be made because it can be made as a clinical diagnosis. However, in cases like Alexia's, where other diagnoses are equally as likely, so ovarian torsion and ovarian torsion or ovarian cyst rupture, imaging can be used to differentiate between those differential diagnoses. So you refer Alexia to the general surgeons for management of her appendicitis, which in this case should be an appendectomy, so a removal of the appendix. And as you wait for the general surgeons, you prescribe Alexia because she's still in a lot of pain. And we prescribe analgesia using the WHO analgesic ladder. And this is a stepwise approach to titrate the analgesia we're giving to a person's pain. So if a patient presents with mild pain, we want to use non-opiate analgesics like paracetamol or NSAIDs. For moderate pain, we want to give weak opioids such as codeine and tramadol. And for severe pain, we're thinking of things like morphine or fentanyl in some cases. So if we're going to give her some opioids because she's in severe pain, what is the most common side effects of opioid medication? So most of the answers are in now. And the most common side effect associated with opioid medication is nausea and vomiting. So opioids can be given through many different routes. One fact to remember about opioids is that they are renally excreted. So it's important to bear that in mind because in someone with poor renal function, so acute kidney injury or any other kidney pathology, the levels of opioid can accumulate in these patients' blood. And if the levels of opioids accumulate in their blood to such an extent, they're more likely to experience adverse drug reactions like nausea and vomiting and constipation. If opioid levels get to such a high extent in a person's blood, they can experience more serious side effects like sedation and confusion and respiratory depression. And the last two adverse drug reactions on this list are life-threatening. So if you want to reverse it, the reversal agent for opioids is naloxone. So we've come to the end of our first patient. Does anyone have any questions regarding anything we've spoken about so far? Okay, cool. We'll move on to our next patient. So our next patient is Harold. He's a 65-year-old male, and he's come in with abdominal pain, which is generalized and sharp in nature, and it comes and goes in waves. It started off as a discomfort yesterday, but is now very, very painful today and is relieved when he vomits. And because of this, he's unable to tolerate any food and drink. He's noticed that his abdomen has become distended, and also that he's noticed that he's previously had constipation in the last 2 months, followed by some diarrhea. Sorry, my phone just vibrated, sorry. Which has previously had constipation in the last 2 months, followed by some diarrhea. So, on examination, this is what you find. So he's tachycardic and hypotensive. And on examination, he looks very cachexic. His heart sounds are normal and his chest is clear. And on abdomen, on an abdominal exam, you see there's clear distension. So given these four symptoms, abdominal pain, vomiting, distension, and absolute constipation, what are these the cardinal signs of? Yep, that's right, bowel obstruction. So the different causes of bowel obstruction can be divided into 3 main categories. The first is intramural, so something within the lumen of the bowel itself, such as a foreign body or fecal impaction. The second are mural causes, so things within the lining of the bowel, so things like cancer or strictures. And also extramural causes, so things like hernia and volvulus, so something outside of the bowel pressing on the bowel itself, causing it to be obstructed. Now, it's important to pick up bowel obstruction because if you don't pick it up, later down the line, it can cause ischemia and infection. So similar to Alexia, we want to order some investigations and can be divided into our bedside, bloods, and imaging. So for our bedside, we want to order an ECG because we want to rule out any arrhythmias and to make sure that his tachycardia isn't concerning. In terms of the bloods, again, we want to rule out an anemia, an infection, an electrolyte imbalance, and also to get a baseline in case we want to do further interventions down the line. Next, imaging. So this can be done either with an abdo-CT or an abdo-X-ray to look for changes in the bowel and to look for any obvious masses. Now, abdo-CT is usually the gold standard for diagnosing a bowel obstruction, but in some places they still use an abdominal X-ray. Now, when looking at the abdominal X-ray, to differentiate the small bowel from the large bowel, there are certain features that you can pick up. So in a small bowel obstruction, the bowel is usually in the center of the abdomen, and you can see valvulae conniventes. So these are lines that run throughout the bowel here. So you can see that these lines run throughout the whole diameter of the bowel. In a large bowel obstruction, you can usually see the bowel in the peripheries of the abdomen, and you can see the lines called haustra. And unlike valvulae conniventes, haustra don't cross the entire diameter of the bowel. They usually cross halfway through, as seen in this picture. So when measuring bowel diameter, over which measurements is the bowel considered to be dilated in relation to the different segments of the bowel? The poll has sort of tapered off now. So the answer to this is C. So above 3 centimeters in the small bowel, above 6 centimeters in the large bowel, and above 9 centimeters in the cecum. And this can be remembered as the 3-6-9 rule. So 3 in the small bowel, over 6 in the large bowel, and over 9 in the cecum. But rather than abdo X-ray, Harold has gone for a CT scan, and this is the results of his CT scan here. So there's free fluid seen in the abdomen and in the pelvis, and there is marked dilatation of over 8 centimeters of the transverse and ascending colon, proximal to a 6 centimeter mass in the sigmoid colon, probable of cancer. So we can establish that Harold here has a bowel obstruction due to a possible cancer or a mass in his GI tract. So in terms of the management of bowel obstruction, this includes keeping the patient nil by mouth, IV fluid resuscitation, inserting an NG tube, analgesia, and referral to general surgeons for definitive management. Now, why do we give IV fluids in someone with a bowel obstruction? Well, in a bowel obstruction, because the contents of the gut can't pass through, rather than going down, it goes the other way. So a lot of the time, the patients are dehydrated because they're vomiting so much. Another reason why patients with a bowel obstruction are severely dehydrated is because of a phenomenon called third spacing. So the bowel's natural instinct to overcome an obstruction is to keep pushing past past the obstruction. So it increases peristalsis. And when it increases peristalsis, it increases the amount of fluid it secretes into the lumen of the bowel. But obviously, in a bowel obstruction that's complete, it can't get through. So it's secreting lots and lots and lots of fluid into the bowel, and it's drawing fluid from the circulatory system into the bowel. And in doing so, the patient becomes clinically dehydrated. So in terms of fluid management, we usually give fluids in 3 scenarios, and this includes resuscitation, maintenance, replacement, and distribution. Resuscitation means they need this fluid now, or else they'll deteriorate very quickly if we don't give them these fluids. Maintenance is when they don't need the fluids immediately. It's not a life-saving intervention. However, they're unable to maintain or keep their own levels of electrolytes and fluids in the body, so we need to supplement that. And we can also give fluids in terms of replacement and distribution. So this means that in terms of the fluid and electrolytes in their body, we want to shift it to the correct places. So in this case, Harold needs fluid resuscitations, because if he doesn't get these fluids, he's going to become very, very ill very quickly. And in terms of the principles of fluid resuscitation, we want to do an A to E assessment. So we want to look at his blood pressure, his heart rate, his mucous membranes, and his capillary refills. And we want to give 500 mL of crystalloid fluid over 15 minutes. And this can be repeated until 2000 mL is given. Now, this is the general rule. The occasions where this rule you need to be a bit more thoughtful about giving fluids is in someone who has heart failure or renal failure. So in these cases, you don't want to fluid overload them. So in these cases, you want to give around a bolus, 250 bolus rather than a 500 ml bolus. And you want to reassess their response to the fluids. So you want to see if there's a change in their heart rate, a change in their blood pressure, if the capillary refill is getting faster with the fluids. And if not, you want to seek help early. So we said that they become dehydrated because they are vomiting a lot. They're vomiting a lot of the gastric fluid and the gastric secretions. And to relieve this vomiting and to make them feel a bit more comfortable, we place an NG tube in. Now, and for most places, to confirm the location of the NG tube, we do a chest X-ray. So there's a chest X-ray on the screen now with an NG tube be in situ. What's wrong with this chest X-ray? Yep, that's absolutely right. So the tip of the NG tube is in the wrong place. It's in the lung. And you can tell that this is in the wrong place because the NG tube doesn't go all the way down. So to ensure that the NG tube is in the right place, what you want to do is track the NG tube from the top all the way down, and it has to bypass the diaphragm, and you'll see the tip here below the diaphragm. And that's how you know it's in the stomach and not in the lungs. So you've done your interventions, but now Harold is complaining of 10 out of 10 pain, and the pain is so bad that he can't move, and he feels that something has gone horribly, horribly wrong. So you go back to Harold and you re-examine him, and you find that he now has rebound tenderness, guarding, and percussion tenderness. So given the signs of guarding and rebound tenderness, what do you think has happened? Yep, so peritonitis. So he's now developed peritonitis. What do you think has caused this peritonitis? Yep, perforation. So in terms of bowel obstruction, peritonitis can occur due to one or two or both pathologies. So perforation is one of them. Another pathology is that there's increased inflammation at the site of the obstruction. And when there's increased inflammation at the site of the obstruction, there's increased permeability of the gut mucosa. And this causes bacteria to move from the inside of the gut into the peritoneum, and that causes the inflammation of the peritoneum. And also the perforation as well. So that bit of the bowel is now becoming ischemic. And because that bit of the bowel is becoming more and more ischemic, it leads to the bowel breakdown essentially. And that leads to gastric content and the contents of the gut filling the peritoneum, and that causes the inflammation. So you do a VBG and Harold. Now, which of the following results would indicate continued deterioration? So in this case, an increasing lactate would, in terms of the clinical picture, would suggest that Harold is continuing to deteriorate, because the reason this is because when the bowel becomes ischemic, it switches from aerobic to anaerobic respiration, and this causes the lactate to increase. So now we're thinking with Harold, he's got this bowel obstruction, but now his bowel is becoming more and more ischemic. And in terms of the management of a peritonitis or a bowel perforation, they can become septic very, very quickly. So we need to activate the sepsis 6 protocol, and part of that is measuring his lactate. So we want to give IV antibiotics, IV fluids, oxygen if he needs it, take blood cultures, and to measure his urine output, and refer him to the surgeons as soon as possible for definitive management of the bowel obstruction. Now, in terms of the management of the bowel obstruction, the emergency procedure done for bowel obstruction is called a Hartmann's procedure. And this involves taking that bit of the bowel which is obstructed and creating a colostomy, which is an outpouching of the large bowel onto the skin to allow feces to leave the body that way rather than through the rectum. So we've finished with our second patient. Any questions on anything we've covered so far? Nope. Okay, so we'll move on to our final patient. So our final patient is Ingrid. Ingrid is a 34-year-old female, and she's coming in with vomiting blood. So she said she's vomited blood earlier, around 1 mugful, and it was bright red blood, not mixed in with the vomit. She drinks around 25 units of alcohol a week and is not on any regular medication and doesn't take anything over the counter. She has no abdominal pain and no history of weight loss, but has no liver disease. So examine Ingrid and you see this. So what does the following sign refer to? Brilliant. Yeah. So these are spider nevi. So spider nevi is not always pathological. This can be seen in pregnancy or women who are on the combined oral contraceptive pill. However, if 5 or more of them are present, this might indicate some underlying pathology like liver cirrhosis. So the other options on that question were also other extra abdominal signs seen in GI pathologies, which we'll quickly go through. So caput medusae is associated with portal hypertension, and it looks a bit like this. They're engorged paraumbilical veins. And the reason this occurs is because the pressure in the venous system causes these veins to dilate and gives you this image. Pfizer-Fletcher rings are seen in Wilson's disease, which is another GI pathology, and is an accumulation of copper deposits in the liver. And typically you will see these dark brown rings around the iris here. Next is Dupuytren's contracture. This is a thickening of the palmar fascia, and sometimes it can be due for other things other than GI causes. So things like a genetic cause, an increasing age, diabetes, or excessive alcohol use. So the causes of upper GI bleeds can be differentiated by where the GI bleed occurs. So from the esophagus, from the stomach itself, or from the duodenum. And different differentials include varices, esophagitis, or esophageal cancer, peptic ulcers, gastritis, a Mallory Weiss tear, malignancies in the stomach, or peptic ulcers in the duodenum, inflammation of the duodenum, diverticular, or an aortoduodenal fistula. So she has an upper GI bleed, and we want to score her risk. So which of the following scoring systems is used before endoscopy to determine the risk of having a catastrophic GI bleed? So the answer is the Glasgow Blatchford score. So this is a score used before endoscopy to stratify someone's risk of having a high risk GI bleed, and it just uses the clinical presentation of the patient. So you don't need to go endoscopy. So this can be used to differentiate between low or high risk GI bleeds. So the other systems, the other scores in that question are also scoring systems used in GI. So we'll briefly go through them now. So the Rockall score is also used when determining risk in a GI bleed. However, this is a post-endoscopy score. So not only is it taking the patient's clinical presentation, but also any signs seen on endoscopy. And any score above 6 is high risk. The Child-Pugh score is used to indicate the severity of liver cirrhosis. And this uses biochemical markers such as albumin and INR, but also the patient's presentation like ascites and hepatic encephalopathy. The ASA score is used when someone is going under not only GI surgery, but any surgery typically. And this classifies the patient's physical status before surgery and determines perioperative risk along with other factors. The score goes from ASA 1 to ASA 5, and the higher your score is, the more high risk the surgery will probably be. So on the left there is Ingrid's history. And given the history, the presentation, and clinical signs that you find, so the spider nevi as well, what is the most likely cause of an upper GI bleed? Yeah, so esophageal varices. So what are varices? So the gastrointestinal system has two venous systems. The first is the systemic venous system, which takes blood from the organs back to the heart. And the second is the portal system, which takes blood from the organs like the stomach and the intestines to the liver for nutrients to be metabolized and other chemicals to be metabolized. Now, there are certain points in the GI tract where these two systems form connections called anastomoses. Now, in these connections, it's usually a low pressure connections. So, for example, up here we have the zygous vein and inferior vena cava, and they have esophageal anastomoses. Now, these are usually low pressure areas. If for any reason the pressure in the venous, the systemic venous system or the portal system increases, then these areas of low pressure anastomoses, the pressure in these areas goes up, which forms outpouchings called varices. And it's these varices that can rupture and cause the variceal bleed. Now, in terms of the investigations and management of a variceal bleed, you want to do things like an FBC and FBC group and screen and an INR because of their bleeding risk, they can bleed very, very quickly. So you want to get blood in them fast, and you want to make sure that if they their clotting is at a good level for them to stop the bleeding. So in terms of management, you want to fluid resuscitate them as per what we've discussed earlier, and also to transfuse them if their HB is below 80. And if they're on any anticoagulation like warfarin or a DOAC, there are reversal agents to counteract the effect of these medications. So if they do end up bleeding, they don't bleed out as much. And because these patients can get very sick very quickly, it's important to escalate them to the appropriate teams like the GI team, ITU, or anesthetics. And all this can be found on the proforma. So this is the UHL proforma for upper GI bleeds. And it's very useful because at the bottom here, you have the Glasgow Blatchford scale, which determines the risk of the bleed, so whether it's a high risk or low risk bleed. But also at the top here, it says the investigations and the management of the bleed itself. Now, as we said earlier, upper GI bleeds can stem from different sources in the GI tract. However, if there's a variceal bleed that's suspected, we have additional steps in terms of the management, which is here in this orange box. Now, the question is, what's in that orange box? So what additional medications are given when resuscitating someone with esophageal varices prior to definitive treatment? So what can we give them in A&E essentially? Yep. So all these medications, all the combinations of these medications are all combinations that we use in GI medicine. However, in this case, for an esophageal varices bleed, it will be C, terlipressin and coamoxiclav. So this was what's in that orange box. So it will say the dose and the route of the terlipressin and also which antibiotics to give. So in this case, ciprofloxacin or coamoxiclav. And the reason we give these medications is because terlipressin vasoconstricts those veins within the portosystemic circulation, and that reduces the blood flow. And if there is a variceal bleed, it stems the bleeding that way. And also, these patients who have variceal bleeds are more prone to get infections. And if they do get an infection, that increases their morbidity and gives them a poorer prognosis in terms of their recovery. So in terms of the other combinations that was on that question, these are what we use them for. So the prednisolone and the mesalazine we use for a flare-up of UC. The amoxicillin, metronidazole, and omeprazole, we give them in terms of H. pylori eradication, especially in peptic ulcer disease, and the chlordiazepoxide and thiamine we give in alcohol withdrawal. And that brings us to the end of our presentation. So that was a bit of everything in 45 minutes in terms of the management of GI emergencies and the presentation of GI emergencies. So we've covered a little bit of a lot. So thank you so much, everyone, for coming this evening. And if you don't mind filling in the feedback with the QR code, that would be much appreciated. Thank you, everyone.